Hi everyone, welcome to another edition of Journal Club with Hirad. This is for March 2022 and we will start with interesting papers that publish in regards to devices in the field of cardiac electrophysiology. Thank you. So let us start to go over those papers. Okay, so we will start with the papers that focused on defibrillators. Two major papers was published in JACC and JACC Heart Failure. First one look at the outcomes in patients older than 65 years old, whether they're getting transvenous or sub-Q ICD. And second one look at the role of NT-proBNP in Danish trial. Okay, we get to this paper that looked at a longitudinal outcome of sub-Q ICD versus transvenous ICD. About 16,000 patients were included. This is from NCDR ICD registry. They look at all-cause mortality differences, device reoperation, device removal due to infection, device reoperation without infection, and also cardiovascular readmission and recurrent all-cause readmission. And if you see between these two groups, sub-Q ICD and also transvenous ICD, there was no significant difference in all categories, nothing. And as well, long-term follow-up, there was nothing significant in events per person as well. But as expected, they've noticed that patients that got sub-Q ICD are more Black, they are dialysis dependent, as young, and less likely patients with flutter and fibrillation getting sub-Q ICD, and most likely because they require a pacing system. But it was surprising to me that the rate of device removal due to infection were same, or no statistical significance between these two groups. Alrighty. So this paper looks at NT-proBNP and ICD in non-ischemic systolic heart failure. This is extended follow-up of Danish trial. So basically, as you know, in the CARE heart failure, CRT were more beneficial in patients with lower NT-proBNP. And the base of all these NT-proBNP measurements is that if you have a higher NT-proBNP level, it indicates that you have more severe heart failure with more comorbidities, and you will die most likely from pump failure rather than the arrhythmic causes. However, if your NT-proBNP level are on the low side, you are more prone to die from arrhythmic causes, so you can get protection from ICD. So they're looking into this hypothesis. The Danish trial, as you remember, randomized patients to two groups. One group received ICD, around 556 patients, and another one had the usual clinical care. As you see on the right side of the slide, on all the different causes of cardiovascular death, death from any causes, and non-cardiovascular death, you don't see any significant differences, statistical significance between ICD and the control group. There is only one area. That's the patients with a low NT-proBNP. They have more protection from ICD. They have a less sudden cardiovascular death. So it's possible that the lower NT-proBNP can be indicator of the benefit from ICD. And that benefit is only for sudden cardiovascular death prevention. As you see also in the lower part, you see the higher level of NT-proBNP is associated with the death from any causes and cardiovascular death. This difference is not as much and is not significant, although there's a trend in sudden cardiovascular death. All right, thank you. Okay, let's get to the paper on hematoma and device infection. Basically, this is a paper published in Europace on antibiotic prophylaxis based on the individual infective risk stratification in devices, the practice study they call it. So they stratified the patient to two groups. One group high risk and another one low risk based on the score called Sharif score. Sharif score give 1 point for each of these risk factors, including diabetes, heart failure, history of heart failure. If you're taking anticoagulants, if you're on steroids, if you have a renal failure, if you have prior history of device infection, if you have more than 2 leads, or if you have epicardial leads or using temp pacemaker before the implantation, or this is a part of replacement upgrade. So all of them will get 1 point. These are, I think, around 11 risk factors. And if you have 3 of them, you will be considered high risk. If it's less than 3, you're low risk. And they gave the low risk patient 2 doses of antibiotics, one before and another one 8 hours after IV antibiotics. In the high risk group, they did differently. They give IV antibiotics for 2 days and then 7 days of oral antibiotics. So 9 total days of antibiotics, and they follow these patients for around 250 days on average, around 8 months. And they found about 1.3% of the patient develop an infection related to device. So basically 12 patients. And if you look on down the slide here, there was no significant difference between the low risk group and high risk group in the rate of infection. Now, is this a good thing? Did we say that with that 9 days of antibiotics, we decrease the risk of infection from the high risk to level that the low risk group gets? So that's still needs to be investigated. It would be nice that if they have another arm looking at the high risk groups with the same level of antibiotic prophylaxis like low risk group, and see if there's any difference between the third and the second arm. Also, they look into the factors that can predict infection in the univariate and multivariate analysis. On the left corner, you can see that they found in the multivariate analysis after adjustment for everything that if you have active neoplasia, if you have hematoma, and also reintervention, that will significantly predict risk of device infection. Okay, now we get to the physiologic pacing. Paper of this month is about Bachmann bundle pacing related to the atrial resynchronization rather than the ventral resynchronization, and is about how to identify Bachmann bundle potential during atrial lead placement. This is a case series published in Heart Rhythm in its March issue. So few backgrounds basically. One is, we know that damage to the Bachmann bundle can increase chance of getting atrial fibrillation, and it can show itself with the increase in P-wave duration. The cutoff, usually they use 120 milliseconds. Also, we know back in 2001, there was a multi-center randomized trial that showed that if you do Bachmann bundle pacing versus the usual area, which is the right atrial appendage, you have a significant reduction rate of atrial fibrillation. Now here they're trying to use EGM and to better identify the location of Bachmann bundle and to show the recruitment of the Bachmann bundle when they placing the lead. Now, as you see here in the panel here on the left side, you see that they identify anterior, superior, and septal part of the right atrium, and they located their lead, which is 3830 leads in Medtronic, and they found these dual multi potential, which they call the first one is most likely coming from the crista terminalis, and the second one they claim that it's coming from the left bundle, the Bachmann bundle. And there's a 38 milliseconds differences between them, and as you see in the lead 2, you have this 2 notched P wave and a very long P wave of about 160, 170 milliseconds. Now, when you pace with the high output, you recruit both of the potentials. Both the potentials come and they get captured. So basically, you're capturing most likely the crista area or close to the crista area, as well as you're capturing the Bachmann bundle. And as you notice in the EKG, your P wave shorten and the P wave gets fused to your pacing spike. Now, when your outputs start to get lower and lower, you start to see the second potential. So it seems you're not capturing the Bachmann bundle as like before, and you get this isoelectric segment now that showed up. But it's still another interesting thing is your P wave gets shorter, and even with lower output, your P wave gets shorter and narrower, and you see the potential. Now, they said that there are different patterns in the series of patients they saw, and some of them your P wave duration might not get shorter or stayed about the same. And also they identified the features that they noticed in the ring electrode unipolar and the tip electrode unipolar. In the ring, you can see this one potential they claim that is coming from crista terminalis. In the tip electrode, you have two potentials, one of them far field from the crista terminalis, and second one, the next one, is a Bachmann bundle potential. And then after defining the Bachmann bundle potential, they showed that the P wave duration was short and the P wave morphology was very similar to the sinus node, favoring activation of the atrium, same as what we see in patients when the patient has the sinus rhythm. They had mapping for a few of the patients, and they showed that this pattern, this way of pacing, will provide resynchronization of the atrium. But still, we need to identify these potentials with better tools. And as you know already, that there are a lot of studies, there are a lot of researches to look into what is the best way to pace the heart. And as you know, the atrial-based pacing reduces the incidence of AFib when you do RV pacing, of course. And if you do a lot of RV pacing, you increase the pressure on the left side and you increase the AFib. But there were a lot of different approaches to resynchronize atrium with the right appendage with the coronary sinus together and high atrium with this. All of these stuff wasn't that much promising yet, so this is a very fresh air basically, and hopefully we can utilize this in the future and provide better pacing for our patients. Okay, now we get to the last paper. This is the paper published in Heart Rhythm March 2022 issue, and looking at the role of the loop recorder in guiding us in patients with cardiosarcoidosis to assist their arrhythmia. Basically, they looked at patients that had a history of extracardiac sarcoidosis. They screened these patients, close to 550 patients. Out of 550 patients, they have this 105 patients that they diagnosed them with cardiac sarcoidosis based on their consensus. Then they have stratified the high risk and low risk group. If they have a low EF, sustained arrhythmia, all of these that indications that we implant ICD for cardiac sarcoidosis. And also if they have extensive lesions in cardiac MRI also was included as a high risk group. So 17 patients received ICD, and the rest of the patient was 88, received 80 of them loop recorder, and they were followed about 33 months, and they were evaluated, they were followed up based on what arrhythmia they had. They didn't specify how much of SCAR was the cutoff for them to include the patient ICD group, so that's something that needs to be looked in. And out of all of this patient, 105 patients, 5 patients, like 4.8% of the patients developed primary endpoint. One had a cardiac death, that was a loop recorder group, and the cardiac death because of the RV failure, so not related to arrhythmia. And there was 4 patients in the ICD group that had a sustained arrhythmia and received appropriate ICD therapy, and 1 patient got appropriate ICD shock. What was notable is that we didn't see any kind of sustained arrhythmia in group of the loop recorder, and some of them got ICD because mostly AV block issue that they developed later on, and there was other concerns that made them to have ICD implanted. So the rate of appropriate ICD and ventricular arrhythmia was 1.7% per year on average, and there were up to 10% in the high risk group, which is significant. Still, given that the loop recorder didn't show anything significant other than the heart block, still we are not sure the loop recorder implantation should be part of this surveillance or not. As we know, patients with the cardiac sarcoidosis, they have a higher rate of ICD therapy and ICD shocks comparing to the same group, the normal or near normal ejection fraction, because of the nature of disease. And the second thing, again, because of nature of disease, we might have problems in the future because of new inflammation and new scar formation that we don't have in other patients that we deal with in category of non-ischemic cardiomyopathy. And so as you know, the consensus has changed, and since this study was recruiting patients, And um, and now, if the EF is less than 35% to 50%, and the scarf is not that significant, you can do EP study, and then EP study, if it's positive, you have indication to implant ICD. So still, we need to know more about patient with cardiac sarcoidosis and how to stratify them, who is high risk, who is low risk, and who will benefit from ICD. Thank you very much. And this is the end of the device part of journal review in March 2020. Stay tuned for other editions of the March 2022. It will be in atrial arrhythmia, atrial fibrillation, as well as ventricular arrhythmia part. Thanks again.